Okay, Assalamu alaikum. Good morning. Thank you very much. When I decided to pick up this subject, I thought it might be easy and I'm familiar with it. But frankly, I didn't know what I got myself into until I went deep and deep. And I decided to do my best in 20 minutes because the differential diagnosis is really huge. So we're going to discuss some common skin lesions that comes with fever and check the differential diagnosis. And every time we have a case, we'll discuss the treatment options. It's not easy, as I mentioned, to diagnose fever with skin lesions. It's really difficult. You need to do thorough history, physical exam, and on top of that, investigations with a radiology, blood, and in some scenarios, you end up doing even like tests other than the skin. You tap the knee, you do LP, of course, blood cultures or skin biopsy. And history is really important. As I mentioned, you have to know immunization status, travel history, contact, and if the patient had any prodromal illness. Exam should be from head to toe. So you start with the head, eyes, the mouth, you check the ears, of course, chest, abdomen, don't forget liver and the spleen enlargement, and do not forget about the lymph nodes and the joints. So lesions, skin lesions or skin rash with fever might be related to infection, but unfortunately there is also some causes of that other than infection: tumors, inflammatory disease, vasculitis, all these. You have to keep in mind drug reaction, non-infectious causes. So don't limit yourself with infection. If you can't find a reason, start looking for non-infectious causes. Let's start with this case. This is a 45 years old male patient, complains of 1 week of worsening right lower extremity redness and pain associated with fever. No past medical history, no meds. He doesn't smoke or drink alcohol, no drug abuse, drug abuse, and the patient having chills with the fever. On exam, he has a temperature of 39 Celsius. Otherwise, his vitals are stable. When you examine the patient, there is inguinal lymphadenopathy. There is, as you can see in the photo, there is erythematous plaque with well-defined borders, and it's tender to touch. Labs showed mildly elevated white blood cells around 12,000. So what is your diagnosis? Cellulitis, tinea, stasis dermatitis, or hemophilia. And if anyone says hemophilia, I'm out of here. So it's cellulitis. Let's start with the basics and we'll go to the more complicated cases. So cellulitis, as you can see, it's straightforward. I gave you a straightforward case to start with to wake you up. Then let's talk about tinea. Tinea doesn't give you fever. Tinea doesn't give you lymphadenopathy or lymphatic streaking. And for the status dermatitis, again, no fever, no elevated white blood cells, no lymphadenopathy. And hemophilia, forget about it, just a distractor. If you bleed, you're going to bleed in the joints, not in the skin. So what do you expect in such a patient with cellulitis when you examine him? Fever, elevated white blood cells in the labs, lymphadenopathy, lymphatic streaking, or all of the above. All of the above. Look for these when you check for a cellulitis. So cellulitis is common. It involves the whole dermis. Usually there is a reason for that, either like a small trauma unnoticed, there is fungal infection. That's why it's always important to treat fungal infection when you treat cellulitis, because the port of entry will stay open and the bacteria will keep coming deep to the dermis, causing recurrent cellulitis. So it's a rule of thumb to treat fungal infection with the bacterial infection. The most common one is group A strep and Staphylococcus aureus, but we can see that in later on many other causes, but this is the most common one. And it's always common is common. Don't distract yourself, treat what is common. If no response, then you have to think out of the box and check other causes. And it's important to treat cellulitis early, especially in patients who are immunocompromised, very old, poor circulation, because if you don't treat early, it's going to keep going deeper and deeper, and you don't want to end up with necrotizing fasciitis. So typically, it's rapidly spreading within hours to days, but mainly within a day. You can, if you mark the edge every day and you see the patient next day without treatment, you see it's progressing. With treatment, slowly regressing. What about erythema? It's non-fluctuant, tender. And what about the most common side? Of course, lower extremities, but you can see it anywhere. And you can see what we call the lymphatic streaking. I'll show you an example. Patient might be febrile and toxic. And you might see elevated white blood cells if it's bacterial, mainly neutrophils dominant, and lymphadenopathy is common. So this is what I call the lymphatic streaking, and usually it's because there is inflammation of the lymphatic vessels. Look for that. When do you almost rule out cellulitis? Bilateral erythema in lower extremities is not cellulitis, unheard of, unless the patient had trauma to both legs same time, port of entry, the same bacteria, which never happens, extremely rare. So don't think about cellulitis when you have bilateral erythema. Don't think of it if there is no fever, elevated white blood cells, lymphadenopathy, and lymphatic streaking, especially when there is bilateral erythema. Think about something else like stasis. Again, bilateral erythema or cellulitis never happens. Usually it's accompanied by lymphatic streaking, lymphadenopathy, leukocytosis, and fever, when the other differential diagnoses are not the same. Let's go to this case, a 58-year-old male patient with diabetes mellitus and hypertension. Right thigh redness and severe pain. No history of trauma. Patient on lisinopril, atenolol, and glyburide. His family history unremarkable. Social history, no alcohol, smoking, or IV drug abuse. He has fever with this redness and pain. So look at the picture and pay attention to this bluish dusky stuff here. This is unusual for cellulitis. Maybe this is cellulitis, I agree with you. But what about here? And what about the severe pain? We said that in cellulitis you have pain, and when you touch it, there's tenderness. But the pain, I never seen a patient with cellulitis crying of pain. They tell you have pain with fever, and when you touch it, they might jump. But severe pain out of proportion should ring a bell for something. So what's your diagnosis? Cellulitis, tinea again, necrotizing fasciitis, or erysipelas? Okay, good choice. So again, cellulitis, you shouldn't see this dusky blue discoloration, and the pain shouldn't be this severe. Tinea, I told you, you should not have this fever, toxic-looking patient. And necrotizing fasciitis fulfills all those conditions. And erysipelas, it's a very red area that has very discrete margin, very superficial in the skin. It's a cousin of cellulitis, but it's not dangerous. And the treatment is the same with antibiotics. So when you talk about fasciitis, it means that the infection is deep to the fascia, which is the layer above the muscles right away. So you are beyond the dermis, down. And it's mainly the same pathogens that causing cellulitis will cause the necrotizing fasciitis, group A strep, staphylococcus, but you might see it with other pathogens, but those are the most common, rapidly progressing over days. So we've seen cases after, like, ended up in surgery after 4 or 5 days. And what is that? Usually it comes after trauma or surgery, but sometimes without any preceding lesions or reason. And it can be associated with the toxic shock syndrome. And what's the treatment? Medical and surgical. You start and hydrate, antibiotic, surgery. You might do MRI if you have the luxury of time to do that. MRI that is the radiology modality of choice to diagnose this necrotizing fasciitis. But frankly, it is a clinical diagnosis. It's better to take your patient to the OR and open up rather than using the whole limb, losing the whole limb. So, as I mentioned, there is dusky, swollen, red plaque with blue discoloration. You might see blisters, and the patient might lose sensation in that area. It spreads over hours to days. And how do you know this patient might have poor prognosis? Delay of diagnosis and treatment, and OR, surgical debridement. Patient is old, patient above 50. Patient has visual problem, so he has atherosclerosis, and also if it involves the trunk. So this is a patient who underwent radical debridement of the tissue, the fascia. Now let's see a new case. So this is a 40-year-old female. She has diffuse erythematous blanching sunburn erythema. This is the blanching area. See, you push with your thumb and it fades, and the redness will come back after a few seconds. So blanching erythema all over. It looks like sunburn. She is toxic. She has temperature 40, signs of septic shock associated with headache, injected conjunctiva, dizziness, myalgia. She's having GI symptoms, vomiting and diarrhea. And she's having a menstrual period, and she's been using the tampons. So what's your diagnosis? Easy. Straightforward. Type. So again, what's the risk factors besides the one I told you, the menstrual period? Surgeries. We've seen it in patients with surgery. Recent surgery end up like this. So pay attention to that. And it's worth touching the redness to see if it's blanching or not. Check the blood cultures. What about recent infection? Or also it might end up with toxic shock syndrome. Toxic shock syndrome. You remember I told you about the cellulitis? You can end up like this. What about the most common one? It is either Streptococcus pyogenes, group A strep, or Staphylococcus aureus. And in Staphylococcus, bacteremia is uncommon, while in group A strep, common. The mortality rate is extremely high in group A strep, 30% versus 3%. GI symptoms are common in the less dangerous form with Staph aureus, the nausea, vomiting, or diarrhea. Finally, in group A strep, the erythema, the sunburn erythema, is diffuse all over, while in Staph aureus might be in certain areas. So how do you manage it? Fluids, antibiotics, but pay attention here. We need something to stop the enzyme production, stop the toxin, the cytokines, and we pick clindamycin with high dose. With the other coverage we do, we have to cover for Staph aureus and group A strep. So if you're going to give, it's normal to give vancomycin plus clindamycin, a high dose of clindamycin, 900 Q8. You know, usually we give 600 Q8. Now we're going to give 900 Q8 to stop the toxin production. Besides, let's say vancomycin, If you are still suspecting gram-negative, which is rare, you can add either meropenem or piperacillin tazobactam. Then finally, if you might, in certain conditions with non-responding patient, you might give immunoglobulins, IV immunoglobulins. Another case, 22 years old male, a college student living in the dorm. I'm giving you a hint that he lives in a crowded area. Or if I tell you a prison mate, or someone came from a huge gathering. So he comes, easy, huh? He comes with fever and mental status change. He's toxic, like febrile, tachypnic, tachycardic, hypotensive. He is uncooperative, drowsy. We have neck rigidity. And as you can see, there's an area of diffuse purpura in the lower extremities, non-blanching, and white counts are elevated, liver enzymes slightly elevated, chest X-ray is okay. Because of the neck rigidity, we did, and the mental status change and the fever, of course, we did LP, and it showed increased pressure, cloudy, increased protein, decreased glucose. What do you expect in the gram stain of the CSF or the blood culture if you do it? So good. Gram-negative cocci. What are we expecting here? Neisseria meningitidis. Good. So just gram-negative diplococca or Neisseria can come in two flavors. One that causes STDs, gonorrhea, causing urethritis, vaginal discharge, dysuria, penile discharge, and it causes also pelvic inflammatory disease, septic arthritis, or neonatal conjunctivitis, or it comes with a bad version. It causes respiratory. First, it stays in the oral cavity and the respiratory tract, causing meningitis, meningococcemia, sometimes hemorrhage in the adrenal gland. And there's a vaccine for that, no vaccine for the other one. Again, what's the treatment of choice for that? Antibiotics. We don't do debridement. Okay? It's mainly meningitis, as you can see here, and bacteremia. You can see pneumonia, other infection, but this is the two big. Bacteremia might be alone without meningitis. Meningitis can be alone without bacteremia, or both. What about this guy? Fever, the answer is there. Fever, headache, anorexia, malaise, abdominal pain. And he came with this rose spot, very small ones, 2 millimeters scattered in the chest wall, in the trunk. What do you think? It's a typhoid fever. It's caused by Salmonella typhi. So this enteric fever will manifest as prolonged fever unless treated. Prolonged. Comes with body ache, abdominal pain, GI symptoms, either diarrhea, most of the case, or constipation, splenomegaly. But pay attention to two things besides the skin rash, the small rose spots: bradycardia in someone who is febrile, and leukopenia in someone who is febrile, and with lymphocytic predominance. So someone with fever, you expect him to have leukocytosis, neutrophils, but it's low and with lymphocytes. And you expect him to have tachycardia. He's having bradycardia. What about this guy, dengue fever? This is a characteristic skin rash. The erythema is all over the extremity, the trunk, with islands of normal skin color. Blanching. If I put my finger there, it will blanch. What the other one was blanching, you remember? Toxic shock. Yes, you're still with it. So this is the two blanching rash, and it comes again with pain everywhere. If you saw a dengue fever patient, he's aching all over. And this is the spots I told you about. I have another, maybe you need 2 minutes, so give me 2 minutes. So this is a guy with positive syphilis screening and skin rash. What stage of syphilis is this? And it's maculopapular rash all over. Which stage? Secondary. What's the primary? It's a painless ulcer in the genital area. What about this? Same thing. Palm and sole. Can you put me back, please, for 2 minutes? Otherwise, I'll go home. Type. Okay. What about what happened? Thank you very much. You start all over? Okay, good. Okay. A 20 years old male patient. He comes with fever for 2 days and body ache, muscle ache for 2 weeks. He has unprotected sexual contact 4 weeks ago. 2 days ago, because of the fever, his GP gave him amoxicillin with no effect. He had the rash. On physical exam, he has diffuse maculopapular rash. He has lymphadenopathy. And as I told you, fever. This is the rash. And what do you think? And add to this, by the way, syphilis also. So what do you think? Acute HIV, allergic reaction to the penicillin, monoclosis, or syphilis? Might be anything. Can be syphilis, can be mono, it can be allergic reaction, it can be acute HIV. His HIV positive test came back positive. So this is acute HIV. We had a case, diffuse rash, his syphilis was positive, and he got antibiotics, a whole scenario, but we knew what happened because of the HIV test. This is an old guy, 60 years old male. He has diabetes, hypertension, developed right-sided chest painful rash with fever. And the rash, as you can see, there's vesicles, there's maculopapules. So what do you think? Zoster, varicella zoster. Sorry. So the zoster happens the following. When you're a kid, you get chickenpox. It's caused by the varicella zoster virus. This stays dormant, the virus, in your dorsal root of the spine. And after a certain time, whether age after 50 or immunocompromised condition, it will manifest as zoster. Come on. I have another three slides. Haram alayk. 3 slides. Okay. Type remote. It's like a police here. Oh my God.
1 minute more, please.
2 slides. Okay. Type. So this is Mr. Smith, 2 years old. He got the chicken pox after 6 years. He got the herpes ophthalmicus caused by the same virus. And the virus has multiple stages. I mean, the skin rash, multiple stages, and they come together. So you can have this stage of the rash with another stage at the same time. And this is specific for zoster. I think this is my last. This is a patient who developed rash after getting amoxicillin. This is drug allergy. And drug allergy can come with fever, any form of rash, but the most common one is maculopapular rash. So always ask about new medications in the last 1 or 2 months. Shouldn't be 1 week or 2. It might be a late reaction up to 2 months. Anything, as you can see. And this is Vibrio vulnificus. And again, who's at high risk of having this? Liver disease, whether it's hepatitis, alcohol, elevated iron, diabetes, cancer, immunocompromised. Again, this is my last slide. Fever and skin rash can happen to huge number of reasons, infectious, non-infectious. Stay vigilant. Common is common. Treat common causes. If no improvement, you jump to the next step, checking for non-common. Don't confuse yourself from the beginning. Thank you very much.